Okay, everybody, welcome to our launch webinar today for Mould Illness Mastery. My name is Dr. Sandeep Gupta, and I've got Dr. Amy Derksen here with me today, the co-instructor for the course, and we're really excited to guide you guys through a few little gems in mold illness. Anything you wanted to share, Dr. Amy?
No, this is just a little sneak peek of what we'll be offering in the course. We had one earlier on a little bit different topic that you'll have access to as well. So just hoping to share a few cases and wet your whistle a little bit and get you thinking about mold.
Exactly. And just on a housekeeping note, if you guys have any questions, please go ahead and put those into the question and answer pane, and we will do our best to answer those at the end of the webinar. If you hang around, we will have a discount for the launch of the course towards the end. All right, I'll pass over to Dr. Amy to just introduce herself and her background.
Yeah, just a little bit about who we are and why we would even be offering a course like this. So I'm a naturopathic physician in Washington State. I've been working with chronic illness now for about 22 years. I was really lucky. I started my career working with Dr. Detox. So right out of the gate, out of naturopathic school, was exposed to Lyme disease and exposed to someone who already had tons of experience working with really complicated cases, and really taught me the framework of it doesn't matter what someone's diagnosis is, how do you step back and really look at the person as a whole and start to think about systems that might be impacting them. We all detox similarly, it's just we all go astray in a little bit different way and we're exposed to different things. Over the years, I specialized initially working with Lyme disease and chronic illness and became very passionate working with autism. So a huge portion of my practice has been working with kids with a lot of vulnerabilities. And what I've learned over the years is really, it's not that different. They're just presenting symptoms in a little bit different way a lot earlier in life than some of my more chronic patients. Mold became on my radar. It set off my own autoimmune illness back in college that reemerged later. In my practice, I actually had a mold water leak and a mold exposure, and we had to evacuate our building. So I had to go through that as a practitioner and dealing with all the repercussions of how it was impacting my staff and being careful with my patients. And then in the middle of writing this course, I had a water leak in my beautifully renovated home that had glorious mold growing all over my garage. That's been really fun going through remediation and dealing with insurance and all those things right now. I do a system of testing called autonomic response testing, and Dr. Gupta does as well. And that was something that I learned from Dr. Klinghardt. The nice thing with something like that is it's a form of kinesiology, but we are able to see people where they are and look at them beyond the labs and start to learn some patterns, sometimes before the research even has caught up with that. And that's a lot of times where we can cut through and see, hey, mold is really the gasoline on the fire of some of these patients who aren't getting better. Some of these other infections really can help us cut through. And so the two of us have actually put our heads together because we've seen some very unique patterns, especially where mold illness comes into play. And we're hoping to share some of those things with you and really help you digest a lot of the other schools of thought out there. Like, how do you put it all together? We've both spent nearly 20 years or more digesting all the different schools of thought and putting it into practice. And that's what we're hoping to share with you.
Yeah, I love that explanation, Amy, how you say that no matter what the diagnosis is, just finding out what are the driving factors in their illness. I think that's a huge shift when, as a practitioner, you make that understand, you get that understanding and start to incorporate that in your practice, right?
Yep, it opens up the world that you can treat just about anything.
Yeah, 100%. Great. Thank you so much for sharing. A little bit about me, and apologies to anyone who's sick of hearing my bio. I'm basically based in the Sunshine Coast, Australia, beautiful coastal area. I'm now an integrative family doctor, or what we call an integrative GP over here. My journey started with conventional medical school, so I am the equivalent of an MD, but we call it MBBS over here. And I actually worked in cardiology and emergency medicine and intensive care, and was pretty much a conventional doctor in all spheres, really, until I had my own little health breakdown in 2005, and I was working in intensive care at the time. And I basically wiped out my own gut flora by taking a very strong antibiotic. And then I wondered, why did I have massive headaches and fatigue and so on? And that led me to understanding that there's actually a really complex balance in the microbiome and in the body. And so that was one little healing experience the universe provided me with. And then there was a number of others along the way, including having a house flood in 2012 and having my girlfriend at the time becoming super unwell and bedbound. And that was the stimulus for me to then say, okay, I'm going to learn about this. And so a patient actually mentioned to me that there was a doctor called Richie Shoemaker who was offering a certification. And so I literally just went online, looked it up, and signed up. No questions asked. I just instantly signed up because it was like, look, I need to know about this. I've got to do it. And that started a whole process of learning. It took me 6 months to get in touch with him and then became certified. I think I was the first physician outside the US who was certified. And then he came over to Australia. And then following that and more study, I started developing a broader approach to this. And I also studied with Dr. Klinghardt much later than Amy did. Just in 2017, he came to Australia and I did the ART training and found out that I had some tick-borne infections myself, mycoplasma, and that gave me a broader perspective on health. And I've also applied that to mold illness. So it's really exciting to bring our brains together here on this particular subject and offer it and see how similar we are in many ways in the way we address these patients.
Yeah, as we've been writing this class together, we're like, oh, I want to take this class. It's funny, as we've been putting our heads together and writing some of this material, or we're wishing this was the class that we would have been able to go to 10 years ago when we were really diving into this. So
100%, because when I learned this, it was very drawn out, the training. I think I was sent a few 1,000-page documents to read, and they were extremely drawn out, like the WHO guidelines and the Government Accountability Office guidelines on mold and so on. And trawling through all these documents, trying to find the information you need versus just having some experienced clinicians just give it to you directly. Yeah, I know which one I would opt for if I had that time again. But I'm grateful either way for being able to learn this art and science of mold illness. So jumping into today's launch webinar and what we're going to be covering. So we're going to talk a little bit about what is mold illness. We're not going to get too academic about it today. In the course, we do get a lot more academic about looking at the history of mold illness and looking at all the evidence and is there enough evidence really to say mold is a cause of chronic disease? And when we might suspect it in a case. I guess this is where the rubber hits the road. Let's say you are a family physician or internal medicine physician, something like that, and you're seeing a number of different patients with chronic illness, or a naturopathic doctor to mention that, but you're seeing so many clients and patients. And then how do you know in which ones that your little flag should go off in your head saying, hang on, is mold a part of this? That's probably a really big part of today's webinar. Just want to cover that a little bit. Just getting you some basic patterns that you can think of that make you think, oh, hang on, this might be mold. Now, it's not necessarily going to be definite straight away, but often then through careful history taking, you'll be able to confirm or deny it pretty quickly. And in some ways, that's very exciting because there's many cases of people who've gone through the medical system, gone from one specialist to another specialist, and sometimes they're referred to as heart sink patients. I don't know, it's a pretty derogatory term, really. I don't know if you use that in the United States, but they get referred to that as that here. And the reason is because physicians' hearts sink when they see them on the appointment list. But the reason their heart sinks is they don't have the tools to identify what's really going on. So they're not fundamentally bad people. It's the reason your heart sinks. Yeah, the reason your heart sinks as a physician is your toolbox is not working for them. And you need additional tools. And all of a sudden, once you've got those tools, they're no longer a heart sink patient. So we're going to present a few cases in which difficult cases were able to be handled once. And that transformative piece was realizing that mold was a major driver behind their illness. Amy's going to talk a little bit about treatment and various facets of that. So we've got treating mycotoxins, we've got treating colonization, we've got mast cell, and so there's many facets to it. And we hope that our course actually provides a structured way of you thinking about treating these patients. And then finally, we'll go into the syntax of what's this whole course about and what are you guys actually offering. Yeah, so if you give us 5 minutes to make a little bit of a sales pitch, we'd be most obliged. Okay, so jumping straight in here, when should you suspect someone with mold illness? Do they just turn up in your room and say, hey, I've got mold illness, can you treat me? Generally not.
Sometimes.
So if they know that you're a recognized expert in the field, then you will start to get people who have already been worked up and just come to you and say, hey, I've got mold illness. What do I need to do next? But that comes down the track. But generally speaking, if you're still a generalist and you're not necessarily advertising or well known for mold illness, these are some pointers. So number one, I think is a really good one, lack of response to functional medicine protocols. So what we mean here is, let's say you've got someone with a number of different symptoms and you take them through the standard functional medicine matrix. So whether that means doing some microbiome work on them, optimizing their nutritional status, optimizing diet, sleep, hydration, etc. Let's say you're doing that sort of foundational work that most NDs and integrative MDs are doing every day. Now, they have virtually zero response, despite you being able to correct some of their abnormalities on tests. So whether it be, let's say they've got some abnormalities on the microbiome test, they've got some cortisol, ACTH anomalies, you're giving them some really good formulas, but they're coming back and saying, Doc, this stuff's not making any difference to me whatsoever. I'm just the same.
Or I tolerated it for a day or two and then it made me worse.
That's another one, isn't it? We could have put that on too. Yeah, so poor tolerance. That's a really good point. Yeah, so yeah, we could easily add that in, lack of response or poor tolerance to functional medicine protocols. One possibility there is they're being exposed to something which is essentially blocking many of their biochemical pathways. And we believe that's how it works with mold illness, is that many of those biochemical pathways whereby people should get improvement with basic functional medicine, those are blocked by mold and dampness. And therefore, until you go and address that mold problem directly, they're not going to get any response, or it'll be minimal. I'm not saying it may not be zero. They can get some minimal response. Like sometimes I do find one thing is these patients will respond well to melatonin, or they will still get a little bit of response to certain things. But most of the, like for instance, most of the microbiome work that you do and nutritional work you do, you probably won't find that they have any benefit. So that's a general pattern to be aware of. So then secondly, if I can speak English, sometimes it fails me, multi-system illness. When we say that, we're talking about, so if an illness is one system, it could be gastrointestinal. So let's say someone has abdominal pain and diarrhea and gas. That's just one system. And then on the other hand, their illness could be more neurological. And that would be like insomnia, anxiety, a little bit of concentration and memory problems. Again, that's one system. So on the other hand, if someone says, I've got all of those gastrointestinal things and I've got all of those neurological symptoms, and I've also got joint and muscle pains, and I've also got no energy, and I've also got skin changes, that's multi-system illness. The more systems they've got involved, the more likely they've got something causing broad inflammation in their body. And certainly mold would be one possible cause. We're not saying it's the only one. It can definitely also be stealth infections, etc., But it's one possibility.
Yep.
Then thirdly, if they've got a diagnosis of a chronic fatigue syndrome, or myalgic encephalitis, or mast cell activation, those are going to be situations in which it's more likely, especially if they haven't been able to find a clear solution to their illness, it's going to be more likely that mold is involved in those illnesses, because fatigue is a major symptom of mold illness. And often patients with mold illness will meet the diagnostic criteria for ME/CFS and or mast cell activation. So there's a big overlap there. And it's worth keeping that in mind, that often mold is a driving factor here. And it's not like the diagnoses are mutually exclusive. They're actually could be seen as just being different levels of looking at their diagnosis. So it's important to know if they've got an established diagnosis of something like ME/CFS or multiple sclerosis, mast cell activation, that doesn't mean they don't have mold illness. In fact, it may be quite likely. Now, the fourth one, which would seem to be quite obvious, but it's often not in consultations, is there is a history of water damage to their home that can be elicited. And so if they come in and tell you as part of the history, and I would say that's fairly rare, but if they haven't already identified their illness, because in general there's not a huge amount of awareness around water damage and mold as being a cause, although it is increasing. But if they mention as part of the history that, yeah, I noticed that there was this one house I really wasn't feeling well in, and yeah, it did have some water problems. Yeah, there you go. They're giving you a massive clue right there. So sometimes one of the big skills is just to be able to go, ding, you just told me. You've just given me a big clue right now. I just need to recognize it. I just need to be able to take that in. And as many of us know, a lot of the time the patient will give you the answers if you're ready to take that in. And sometimes it's just a slight clue that you may have to tease out a little bit. So it may be that they mention that, oh yeah, that when I was living in that old house, yeah, maybe things did get worse there for a few years. And then it may be further questions like, okay, was there history of leaks in that home? Was there any musty odors? Did you notice that there was any cracks in the paint or in the wallpaper there? Did you notice you felt better when you went away from that home? So we'll give you all these kind of questions in the course, but sometimes you have to tease it out. And the funny thing is, many times they may not say yes at the time, but they'll actually come back and send you an email. I've found that they say, hey, doc, I thought about this a little bit. You know what? That place did have a couple of leaks, because it may take them a little while to recall these things. So it's also important to keep the door open if they remember things at a further stage in future. So there's certain symptoms are a little bit more classic. So we said what? Static shocks, vibratory sensations. There's some of the ones that are a little bit more classic, but in general, I would say also insomnia. Chronic insomnia is very classic. Yeah. And then allergic shiners. You mentioned that one, I think, Amy. What do you notice about that?
Yeah, so you tend to see, I have them right now, like the puffiness under the eyes. It's really pronounced in kids. Sometimes you're thinking, when you look at them, you're thinking iron deficiency, but a lot of times those eyes are the giveaway. When mold, it's more of a histamine type reaction, but it's just a really specific look. It's just that always puffy and a little discolored underneath.
Yeah.
And that was my big tell with my water leak here. Before I knew there was a water leak here, is my eyes I was needing to use more concealer, all this. It was getting like this rusty color. And I knew something was going on, but I didn't know what. And then you were like,
do we have photos?
Huh?
Do we have photos?
Of my eyes?
Yeah.
I do not. It's not a moment that you're really like, oh, I want a selfie of this one, but I should have. But I have photos in the house. Yeah.
Okay, done. And then the other thing would be chronic sinus issues or recurrent infections. That would be the other one, I would say. And so oftentimes, let's say you're doing ART testing and you find someone's showing up in the nasal passages or the sinus area recurrently. and they're showing up for mold remedies, yeah, you've definitely got to take the clue at that point that there's likely to be some kind of ongoing exposure. I would say it's less of a thing if someone just has it once or shows up with a sinus problem once. It's less predictive, but if it's recurrent, then that's going to be a very strong indicator. And then someone just coming back with respiratory illnesses again and again, that's quite classic because mold definitely suppresses the immune system and specifically around that immune response to respiratory infections. So that's definitely another pattern. So hopefully this has given you guys a couple of little things to think about. And of course, there's going to be more of that if you decide to do the course, just to give you different patterns that you can recognize and start integrating into your thought pattern of when you assess a chronic illness patient. Anything else on that you can think of, Amy?
Yeah, I would just say on the recurrent illness, it's a lot of times what I'm seeing, it's the person who they get a little bit sick every month. No one else in the house is necessarily sick. They might have a low-grade fever. They just feel a little run down. They're never quite well for more than a couple weeks at a time.
Yeah,
with kids,
right,
a lot of times I'm seeing they're getting ill month after month with a little something that's going around and they can't quite get it.
Yeah, that's a good little refinement there. It's almost like that they just keep breaking through. They can't quite get on top of whatever infections that they have. Yeah, that's a really good point. Okay, so we're just going to jump into a couple of cases here, guys. So what we're hoping is that these cases will illustrate some core principles in working with mold illness that might be helpful. If there's any questions about the cases, feel free to put them in the question and answer pane. So this first case we're calling Miss Denise. She's a 39-year-old female. She presented as being unwell for around 18 months with anxiety and insomnia, and it was pretty crippling. Like, it was definitely affecting her life. She wasn't able to function in her job or in her relationship effectively. She'd been to conventional MDs and used around 7 different antidepressant medications without satisfactory response. And I think this on its own, it's another little, you could easily put that as another box on that previous slide. If someone's just trying multiple medications for depression or anxiety and it's not having any response, that could be a sign as well. So she had some response from oral melatonin, as I mentioned before, because that is something that's part of actual mold protocols, and often it will give some benefit. But still, despite that, she was having very patchy sleep. Also, when you went deeper into the history, she said that she did have muscle pains and fatigue at times, particularly after a poor night's sleep. So she had been to see a functional medicine practitioner prior to coming and seeing me, and she had some testing with organic acid testing with Mosaic Labs, GI map, which is a PCR-based microbiome test, and then serum methylation profile with doctor's data. So let's jump right in and have a look at those. So you guys would have seen that this is actually the old version of the Mosaic oat, I believe, but the markers are very similar. And so, as you probably know, the first 9 markers are considered to be the yeast and fungal markers. And so you can see here, number 2, 3, 4, and 7 are highly abnormal. And so that's definitely pointing to something in the fungal realm here. Now, arabinose, number 7, is more thought to relate to yeast rather than mold. However, all the ones that are considered to be furan markers, which is 2, 4, and 5, are considered to be strong mold markers and related to Aspergillus, while some of the other ones are related to different molds other than Aspergillus. In this case, we'd be highly suspecting a problem with mold because of that. So I believe the functional medicine practitioner just suggested a bit of nystatin, but didn't think anything of those other markers. And so this is the next thing, is on her GI map, she actually showed fat malabsorption with that high steatocrit. And also she's showing pancreatic insufficiency. And this is something that hasn't been talked about a lot in most of the textbooks and so on, but this is an association I'm seeing a lot. Pancreatic insufficiency seems to be caused by mold in many cases. So that's definitely something you can take note of. And then she also had slightly elevated or borderline elevated secretory IgA, which means the immune system of the gut is activated. Luckily, in this case, the zonulin's not elevated, but often it will be because they can develop intestinal hyperpermeability in mold-related issues. And if it goes all the way...
Sorry. One note I would add that on the pancreatic insufficiency and even some of the fat malabsorption is Dr. Pompa presented several years ago at a conference and was talking about chronic inflammation suppressing the GAD3 gene, which is related with bile flow and some of those things. And that's why some of the thought with a lot of our chronic patients is all of this digestive distress, the lack of production of enzymes, the lack of getting the dysbiosis basically from the malabsorption and from the maldigestion, because it's fat sitting there and fermenting. And because I see this a lot in kids, and it was always a big question mark for me of how in the world are all these kids struggling so much to make digestive enzymes, and mold can be a huge one, and so can some of these other chronic infections.
Okay, great. And so is there any particular markers then you're looking for?
No, I always look at this on the stool. It's probably the most straightforward, but if you see this pattern, the question is always step back a little bit. Why? How come you have pancreatic insufficiency? How come you're not digesting your fats? You can give temporary Band-Aids right now to do it, but you should be thinking, okay, there's gasoline being poured on a fire somewhere. And is it mold?
Okay, gotcha. Yeah. No, that's a great tip. Thank you. Okay, and then looking at the opportunistic and overgrowth microbes, obviously you can see there's a lot of red here. We've got Bacillus species. Now, sometimes that can be simply because people are taking megaspore biotic or similar spore-based probiotics, so I don't necessarily put as much stead in that one. But Enterococcus, Pseudomonas, and Streptococcus are definitely dysbiotic, large intestinal organisms, and then Methanobacteria are going to be more small intestinal bacteria and often will correlate with methane-positive SIBO. And so it did appear that she had a degree of SIBO, but even once she was treated for it, she just kept on relapsing. And that's a really common thing as well, that you'll see that patients will have SIBO and they'll keep relapsing until the mold is treated. And then this was the plasma methylation profile with doctor's data, and it did show that she had very deficient SAMe as compared to the SAR, and very elevated homocysteine levels. So that you can see that in any form of chronic inflammation. And so that's actually quite a severe example. But it's worth noting that sometimes you will see quite significant methylation abnormalities, and definitely I agree with it being treated, like using some SAMe or TMG or whatever combination that you like to use. Some people like to go and have a look at the genes once they've found that there's such a strong methylation anomaly. But whatever protocol you use, it's certainly worth correcting that, even if they don't have any symptom improvement.
Yeah, and you can track that homocysteine really easily, and it's covered by insurance, right? So ideally, we want that homocysteine between 6 and 8. If it's sky high like this, there's a huge inflammatory component. And so it's a really nice way to gauge, are your treatments working, right? Because when you're doing the right thing, you're supporting methylation or you're dealing with the mold, that homocysteine should come down.
Exactly. Okay, so as I previously mentioned, the patient had virtually zero response to functional medicine interventions for the microbiome and methylation. She did get some benefit with oral melatonin for sleep, but it was still very patchy. She came to me because she wanted to focus on the fungal signs on the organic acid test, and because she felt they hadn't been addressed properly by the previous practitioner. And further history delving into it showed that there actually was a clear exposure to a water damage building, and it did correspond to the timeline of her symptoms. So that's a whole piece that we'll also go into a lot in the course. Now, unfortunately, the exposure doesn't necessarily always match the symptoms. And we'll talk about why. But in this case, and in some cases, it can be very clear, like literally they move into a water damage building and boom, the symptoms start. And of course, that's a pretty clear diagnosis at that point. I think you can diagnose it just on the history, really. But I try and get a fairly economical mold panel done. And this one is Altus Labs in the United States. And it basically, we're talking about this test. It's quite a useful test, and it tends to correlate with exposure. And so if they have the molds that are in pink are 3 or 4 plus, so very high. The ones in yellow are 2 plus or moderately high, and the ones in blue are 1 plus or a mild reaction. And then the ones in white, there's no reaction at all. So you can see here probably 3, 4, 5, 6 are very high reactions. So there's definitely been some exposure to mold here down the track. And sometimes for family members who are doubting the mold connection, just seeing this and seeing the names of the different mold, and of course there's also Candida albicans in there, which is not a mold, it's a yeast. So that correlates with the arabinose on the organic acid test. So she clearly needs treatment for yeast as well. But for family members, this can be really helpful just to see that, okay, these are common molds and you're showing a high level of reactivity to them. Sometimes with the more complicated tests, they may not be able to understand it as readily. And then we also ran the serum mycotoxin antibodies testing. And interestingly on that, there was one that showed up much higher than the others, which is the vomitoxin on the IgG, which tends to correlate more with colonization or infection. And then there was just a few mild reactions on the IgG, which tends to correlate more with mycotoxins exposure. So that's helpful in that there's 2 different mechanisms which are being pointed out on this test. And so that can help to direct the treatment to some degree. We will be giving like a little cheat sheet of different molds and mycotoxins and which agents, whether pharmacological or natural, seem to be most helpful for them. And this is different to the ones that have been included in various books and so on in the past. That's my case, pretty much. Yeah, so basically I explained to her, rather, the nature of the illness and different mechanisms for mold-related illness and how they could be causing her symptoms. And she started on a regime targeting mycotoxins, mast cell activation, mold and yeast colonization, liver and gallbladder detoxification, and GI dysbiosis. We also then were able to find a mold inspector and remediator, and the patient is now working through the difficult problem of whether to move or remediate. But if you can get them to that point, you've already helped them a whole heap, because they then understand one of the things that's driving their illness, and they can then make an informed decision about what they want to do moving forward. Anything you wanted to add on that, Amy?
No, identifying that for the patient, realizing that mold is part of the problem, it gives you a little sense of control in some ways. Because
Yeah, that's right.
this is the problem. I can be very targeted at how do I eliminate this from my body? How do I identify in my environment where big exposures might be? It gives you a little bit of control.
Yeah, that's right.
Yeah.
And then we got yours.
Right. So this will be our other case. So 6 years old, when I started working with her, she was a little younger. We'll just call her Cutie because she is. This is not actually her, but her symptoms started at age 3, sudden regression. So she had keratosis on her cheeks, which is like the little red kind of chicken skin feeling thing. She had it on the upper arms as well. Purple under the eyes, so she definitely had those allergic shiners. And then it started with a coughing tic. So she was always coughing, but it wasn't productive. She wasn't actually sick. This lasted for a few weeks. And then urinary frequency started. And I tend to see this in my little girls more than my little boys. But the urinary frequency is a huge sign for me when it's not actually a bladder infection. So I'll show you some labs that had come up with her, but repeated urine testing was clean. Right? There was nothing going on there that they saw, but it was cloudy. So a flag that maybe it was oxalates. So I'll show you what that would look like. But I tend to see the frequency Kids are sitting on the potty or they're wetting the bed all of a sudden after they've been potty trained. They just don't want to get up, or it can be a big problem. We don't tend to see the fever with it. We don't tend to see actual illness, and the urine test is clean. So that's one of my biggest flags in kids. So she's needing to urinate, but nothing was coming out. Then she became really afraid of germs, had some OCD-like behavior. So it was really impacting her. Constipation developed. She had itchy eyes, some sensory issues. So tags were really bothering her. It was a big deal to get dressed in the morning and to find some things that she was comfortable with because everything was just heightened. And again, I think that can come back to those oxalates. And a spike in symptoms whenever she was stressed or ill. She would have a lot more behavior symptoms and a lot more urinary symptoms whenever she would get a little sick. Okay, let's do the next slide. So her unique history, it's not always straightforward, and I wasn't yet working with her at this point. So I saw her about 2 years into her journey. So when we started asking the history, because when she came to me, she had already seen a lot of specialists, and this had been going on for nearly 2 years. So the school had asbestos that was fully remediated. She had a cough type tick that started after visiting that school. It became worse at that point. She does live in a damp, warm climate. We won't say where, very warm, very damp. So I tend to see a lot of mold in that area. She had spent a lot of time at her grandma's house that had found, after the fact, that found black mold within the vents and in the ceiling and had gone through some remediation. And she had spent a lot of time there around her like pre-K and after school care time while her parents were at work. She was at grandma's house quite a bit. It wasn't like one of these sudden things. It wasn't like, oh, the first time she went to grandma's house, she had symptoms, but it was this sort of slow thing that we look in the background. There was a year of the first year of her symptoms being there. She was at grandma's house almost every day. Mom has lots of allergies and a positive ANA. So the autoimmune type vague history with mom. A lot of viruses that at the start of preschool, which may or may not be abnormal, but again, it's just something unique with her. She just kept getting sick over and over again. Red dye, big trigger for her. Sugar, big trigger for her, and especially a big trigger for her urinary symptoms. But she was growing normally and her energy was great. So that's our other flag to go, okay, wait, she's developing normally. Her energy is good. So this is probably not a mitochondrial issue. This is probably not like some big infection, but what's going on? Clearly she's reacting to something. So let's go to the next slide. Okay, so she started with conventional docs and then had a really good functional medicine doc before she found me. So some of the abnormal labs that had come up, she had low pancreatic lipase in her stool. So some of that pancreatic insufficiency. She had high lipids. So I see the lipids, especially in kids when they spike high, can be this protection. I think it's the body trying to protect the nervous system from some of these toxins. So a lot of times you'll see in your practice, whether it's kids or adults, I have a practice full of skinny women with really high lipids and they eat so clean. So this is not a dietary thing. This is a body protection sort of thing. Elevated creatine kinase and elevated CK isoenzymes. So this was a huge one that sent them on a journey to every possible specialist that you can imagine because they thought something was going on with her heart. And not to say that it wasn't, but why? That was the question. Why all these weird symptoms and why are these enzymes so crazy high? The other thing she also had really high was elevated AST and ALT enzymes. She had a CMV.
Sorry, just to interrupt, do you know if the troponin test was positive though? It probably
Troponin
wouldn't
was
have been.
not positive. Yeah. But pretty high AST and ALT, which again is unusual in a child. And then MTHFR, she's the A1298C, just heterozygous. So is this a big deal? Not necessarily, but this was some of the information that we found. Some of the normals though, CBC normal, strep antibodies normal, CRP levels were normal. So we didn't see that flat out inflammatory piece. Homocysteine had also been normal, negative for ANA. Zinc levels were normal. I think it's important to check for zinc deficiency. She had done a tick-borne panel. That was also looking normal. Screen for mycoplasma and quantitative immunoglobulin. So this wasn't immunodeficiency. They ruled out a genetic disorder and they ran myositis antibodies, which were negative. Okay, let's go to the next one. So when she came to me, she had a list of every specialist you could imagine. So her primary care doctor, she had been to an endocrinologist, a urologist, a cardiologist, the orthopedist, the rheumatologist, the GI doctor, and a neurologist, right? Whatever you have, at that point, she was 5.
It's insane, isn't it?
who's seen all these things, but she's happy and she has good energy and she's growing, but her labs are terrible. And she has this coughing tic and she'll go through phases where she is having to pee all the time, but nothing's coming out, or she's fine. And so it was horrible, not horrible. And it was just this cyclical cycle. And none of the specialists could figure out anything other than tracking the same old labs every time and banging their head against a wall of why it was happening. And the first thing that the parents asked me for is why they sought me out is they wanted someone to step back and look at the big picture, because she doesn't have a need for all of these specialists. Whenever it's like multi-system, you're looking at what is going on. You have to look, there's got to be a common factor that's leading.
Yeah, exactly.
Okay, go to the next slide. So some of the labs here, you can see her liver enzymes got pretty high, especially for a kiddo. The lactate dehydrogenase was high. Creatine kinase would also be high. So there's evidence of this, probably heart damage or muscle breakdown. She wasn't presenting as pain or weakness. It was really unusual. Yeah, very unusual. She would get tired during some of these phases when she'd be at her worst, but
no muscle pain at all.
Not really. Not like you would expect. It was a really unusual sort of finding. Let's go to the next one.
Let's see. That's the thing with kids, though, isn't it? They don't necessarily report. Yeah.
They don't report. You have to observe kids. The one thing I've learned with working with kids is if you ask them where they hurt, they're going to just make something up, because kids don't identify pain in the same way that we do. And yeah, it's interesting. You just have to observe. If their tummy's hurting, they're probably posturing, or they're posturing over the back of the couch, or they're taking their hand, they're pushing it on their tummy, or they're wanting cuddles. Or if their head hurts, they're burying their head in your lap, or standing on their head. Okay, so I wanted to show normal urinalysis looked pretty normal. Trace leukocytes, and the pH maybe a little alkaline. But otherwise, this is a pretty normal looking urine for a kid that is clearly having urinary issues.
Yeah, you guys get much more thorough urine analyses over there than we do.
We get what?
Much more thorough urine analyses. This is
great.
Yeah,
this is great. We can get a same day back as well, covered by insurance. Yeah. Okay, let's go to the next slide. So I ran mycotoxin tests on her because I was suspicious from where she lived. And part of it was taking a good history, finding out what they had tried, what had worked, what hadn't worked. Nothing really was working, but a lot of the specialists, no one really had any ideas of what to do, right? So she had all these diagnostic workups, but really no treatment. And so stepping back, okay, there's got to be something. I want to know if this is mold, because I was very suspicious of it. The other thing that would have been on my radar would have been a tick-borne illness, right? That had already been excluded. And I also did ART and it didn't show up there. So mycotoxin testing had 3 markers that were quite high that all pointed towards Aspergillus, which is what was confirmed later to be found in Grandma's house. Nice thing is she stopped going to Grandma's house even after remediation.
Grandma's fault.
It's sure, it's Grandma's fault. It's always Grandma's fault. So let's go to the next slide. So this is just more of that same, just so you could see the mycotox panel. These are just those same markers, and some of them that are normal. If you could just show the next slide. So one I like to look at, and this was a tip I learned from Jill Krista, and maybe it's an oversimplified way of doing it, but the MPA, that mycophenolic acid, Jill Krista refers to as mold farts, right? So this is the mycotoxin that we would see in living mold. So typically if there is colonization happening or a current exposure happening, you would see this elevated. So it was reassuring to me at this point, by the time we ran this, Grandma's house had been remediated. She hadn't been spending any time there, even since the remediation, for at least 6 months. And I'm suspicious at this point, okay, this is old exposure. We just have to clear the toxins out of her. Probably don't have to focus too much on antifungals with her. It's not a cut and dry, but if this was high, I know we need antifungals. So that was just reassuring of this is probably old stuff. Okay, let's go to the next slide. Ran some blood work on her because this poor little kiddo was a champ and she had labs run probably every 3 weeks. TGF beta 1. So this was when the reference range was actually really useful and they didn't change right now the normal reference range goes up to, I think, 24,000. It's a little bit different technology of how they're using the test. Clearly the TGF beta 1 was elevated. And I think of this, just an oversimplified way of thinking of this, as an acute inflammatory marker related to mold. So I know she's mounting a response currently to either some of those mycotoxins or molds. And her Candida immune complex, which is something that we can run with LabCorp and get some coverage for, was nice and low. So I'm not thinking, because I'm really looking with this child, something's triggering her immune system, and I don't think it's Candida. I'd screen this one a lot in my patients because I find it's quite high in many of our.
And that's like an IgG marker, or?
It is like an IgG marker. Yeah, it's a unique one. So a lot of times I'll run a Candida IgA, IgM, IgG, and the Candida immune complex to get an idea of where the Candida might be.
Okay, great.
And sometimes just the IgA will show up. I know it's either sinus or gut then. But yeah, sometimes the Candida immune tends to be the most sensitive. All right, and then stool testing. So this was a Genova GI-FX. Looking here, low protein, which I thought was interesting. And she was not vegetarian or vegan. And she did have these high triglycerides. So again, this goes back to, she's probably not breaking down her fats that well. Now, it's not as severe as the case that we saw with Sandeep, but this is also a child, right? So it shouldn't be that severe as an older woman. So I know that there's some fat malabsorption happening and probably something going on disrupting bile flow, which was really my big flag I'm seeing here. The nice thing I also look at is that calprotectin down at the bottom is nice and low. Eosinophils, so that marker of histamine, is in that yellow range. So it's a little higher than I'd like to see. So I am thinking, okay, she might need some antihistamine help, especially when her urinary symptoms or her sensory issues are showing up. IgA level is creeping up there too. So IgA levels, when they're up, so I always think of this as our army defense. It's our antibody defense in the nasal passages all the way down through our gut. So if it's high, we're going to tend to be overreactive to things. So I just know she's a little bit of an overreactor to things, and that bile is not helping her at all to get those mycotoxins out.
That's very interesting.
Yeah. Any other comments you have?
No, I think not at this point.
Okay. Yeah, feel free. And then this is still on the GI effects. We're just looking at our good bacteria. A lot of times I'm seeing that no growth of the acidophilus levels there. So something is starving it out. You can give all the acidophilus in the world. It's not going to get those levels up. You have to look at something is shutting it out. And that's where I've shifted to doing a lot of the tiny health stool testing now, or some of these others that are really looking at the full breakdown of everything that's there. So you can decide what prebiotics, what fibers you need, and who you need to kill off and who you need to support. Her bifidus looks really good, though. That's lower digestive function. So I was pleased about that. This E. coli, this is the healthy E. coli, looking a little on the low side. So I know upper digestive bacteria are being compromised somehow. And then when we look at these additional bacteria that shouldn't be there, this isn't too terrible. Sometimes I'll see some of these where it's just like it lights up. They're all in the 4+ range. So I'm not seeing a ton of overgrowth, but I'm definitely seeing this tendency that the bacteria that are thriving are not the ones that should be. And if nothing else, that's what that tells you. And I do see a culture result for Rhodotorula, which doesn't commonly show up here. So again, I'm thinking more, okay, this fungal mold tendency for her, because it's hard to get yeast and mold to grow out in culture. And so when it shows up here, you should pay attention.
No.
Okay.
This is the doctor's data, right? Or not?
I think this was the Genova GI-FX.
Okay.
So it was either Quest or LabCorp. I just ran an oxalic acid. I do the oxalic acid in the mosaic oat test a heck of a lot better. I find it more sensitive. But the thing that's nice when you can run it with your local lab is you get results in 2 to 3 days. Now, as of 2 to 3 months ago, LabCorp stopped offering it. I threw a fit on that one, but it hasn't helped. So we haven't been able to do it, but we were able to measure this with her when she was in the middle of a flare. Now, she was in the normal range, but at the high end of normal. So it was just a flag to me of, okay, oxalates could be part of this. And I had her on treatment at this point. Okay, let's go to the next.
Okay.
So sometimes it'll come back crazy high. This was the oat test. And here you can see it. The oxalic acid is through the roof. Yeah. So we know oxalates are there. So yeast and mold tend to make a lot of oxalates. So I think of oxalates, they're sharp crystals, right? I used to work in a lab doing urinalysis. So oxalate crystals on there, they shine, they're beautiful, but they are sharp. And so they can really cause a lot of urinary discomfort and cloudiness when you're urinating. The other area that we really tend to see symptoms, especially in children, is those small blood vessels, like the eyes. So people who want to put pressure on their eyes or like press on there, or it just feels like all of a sudden your vision has changed, a lot of times can be from the oxalates. It can also cause, because they're sharp, they can cause a lot of joint pains. So I'll see these spikes that'll come and go. So just pay attention to some of those things. So symptoms that we see: pain, sometimes peeling skin, aggravation of Raynaud's, skin can slough off, urinary symptoms for sure, especially frequency and that sharp pain, kidney and cardiovascular damage, early stages of osteoporosis because it disrupts the calcium. And then you might spill more potassium and see more POTS symptoms with that. Okay.
Maybe this is one reason.
The other thing I would comment, just since we're here talking about it, is that marker 20, the glycolic acid and the glyceric acid, if those are elevated as well, especially if you had looked at your first page of an organic acid test and didn't see a lot of fungal tendency, then we're thinking more of a genetic tendency towards creating oxalates. That would just be the key thing there.
Okay.
All right. So this was my general treatment strategy, and I wanted to present this. Now, Sandeep and I did another one of these hour-long little pre-launch courses that there's access to for any of you who want access to that, where we talked a bit about some things that we'll be teaching in the course, which is the overall sort of treatment schematic that you think about. And so I wanted to lay it out in a similar way, just so you can think about how I applied it to this case. So binders are really important. So binders are things that are going to mop up anything that's being excreted in that bile that's in the gut, so it prevents it from reabsorbing. So with her, I used something called GI Detox Plus from Biocidin Botanicals, one of my favorite kind of all-purpose binders that doesn't tend to be too constipating and covers a lot of our mold, and also really great for any sort of die-off with any sort of antimicrobial protocol. She needed help pooping because she would go through phases of constipation. So I chose magnesium citrate for her, for one that brings some water into the stools, makes the stools a little softer, but also it binds up oxalates. So it's a
I was going to say that. Yeah.
The other thing that I really like is aloe. So not all aloe is the same, but some of the aloe capsules can be really helpful for one to get the bowels moving a little bit better, and also acts like a gentle binder. So it can be really helpful. I've seen with some of those chronic constipation cases, aloe can be really good. Antimicrobials, she ended up not needing them. I had considered some fluconazole. I like that it's a Th1, Th2 modulator. I ended up not doing it. Her, like we said, the MPA on the mycotoxin test was negative. I had ART tested her. She didn't seem to need it. And she actually responded so amazingly well just to some detox support, especially glutathione support, that we ended up not needing to go that route.
Yeah, I often find that too, that the pharmacological meds are only needed in a small proportion.
But man, when they work really well.
Yeah.
I write a lot of antifungal prescriptions. Yeah. So yeah. So they're not always needed, but yeah, don't be afraid to use them, and don't be afraid to use them for a while. But identifying the source and limiting exposure was a big thing, right? It's not always so obvious. Your first question on a complicated case like this isn't always tell me about grandma's house. It takes figuring out what's your questions that you're asking, and you really are playing a detective and listening to their history. So part of it was getting out of grandma's house and having grandma's house remediated.
Fire grandma.
Don't get rid of grandma, just her house. Detox and drainage support. So we're thinking of ways to help. So to help kidney clearance, digestive clearance, how to move the lymph, how to sweat better, lots of things. So homeopathy can be used. Herbs can be used. We will go into this in detail. With her, I used milk thistle because those darn liver enzymes of hers were high, and that's one of my favorites. I would also think any sort of phase 2 liver detox, like something like amino detox, could have been really good, but she's a little one and wasn't swallowing pills, and it tastes pretty gross. Molybdenum is a mineral I find that's really important, opens those sulfation drains. Basically, it unclogs the drains and helps things move through. Very easy to take, really helps with some of the sensitivity. And glycine, because she was having some sensory issues, some anxiety, some OCD, and glycine is very calming to the nervous system, but also really good to help excrete chemicals. And that's what mycotoxins are, is they're chemicals. So that's really good, and it tastes good. It tastes sweet like sugar. Glutathione support incredibly important for her. And the thing that I love about working with kids is, man, would they respond quick. There's no gray area. With a lot of our adults, sometimes you throw things at them, there's mental attachments to everything. Kids have no attachment. They don't like to take stuff, but they don't have any belief that they can't get better, right? So glutathione was incredibly important for her. And so was N-acetylcysteine. So I like N-acetylcysteine as a precursor to help keep that pathway working, where sometimes if we're just taking glutathione, I think with that negative feedback loop, we're shooting ourselves in the foot over time. So those two things together were really good for her. And then working on bile flow. So I used a little TUDCA with her and castor oil packs over her tummy and liver. Castor oil, really anti-inflammatory, helps the bowels move a little bit better, helps open up those bile ducts to get some movement, and it is just really soothing. And then for symptom help, because you have to think about that too, right? So we're trying to figure out, what do we do for that? But someone comes to you because they're not sleeping, or their skin hurts, or they have a rash. You have to address that too. So I gave her some mannose for the urinary symptoms, because that decreases bacteria from sticking to the bladder. It's really soothing. Again, it's pretty easy to take because it tastes good. Vitamin K2, specifically for the oxalates, and also directs the calcium where it needs to go. Get them out of those oxalate crystals, get it back into the bones. You can do K2 as drops, really effective. Theanine to help with the nervous system. She could do these as gummies when she wanted to, just to help to calm her down when she would go into some of these fits. And GABA was also incredibly helpful for her as needed, not needed all the time. So that's just the general way.
Right. What a protocol. Great.
Yeah.
And notice no high dose vitamin C. So you don't want to dose high dose vitamin C when someone's got high oxalates.
Right.
Throw that in.
Yeah. Okay, so this was something that we presented last time that we'll get into in the course. So preliminary testing when you suspect mold. So this is just to take us back a little bit. So start with a history. You don't have to start with the fanciest labs, right? You take a good history. What's their living environment like? Don't ask the question. I have it in my questionnaire of, have you had a known mold exposure? People are almost always going to say no, unless they really figured out that there was a big mold issue. So you have to ask those things. Hey, was there ever a leak in your roof? Did you live in a house built before 1950? Did you have a water heater that had leaked that had to be replaced? Or were there carpets where you were always having to clean the carpets with one of the carpet cleaners and there was a lot of dampness? You just have to ask some really specific questions. People get a little defensive. They get a little defensive, right? As if you're criticizing them. And you're not. So you just have to be really open of, hey, I'm investigating this with you. I've seen some of the most beautiful homes. Like I remember one of my first exposures to mold illness was someone living in a multi-million-dollar home in the LA area it was less than a year old. And it was so airtight that they were getting condensation on the wall and it was just shiny. It didn't look like mold that you would think of. And their son got so sick with an encephalitis that they had to evacuate the home and left it sitting there. I went by the home a couple years later and it was still sitting as is with the clothing out and everything else. It was crazy. Back to the history. So investigate the previous living spaces that they lived in, not just where they are now. And the other thing is, think about work environments, school buildings. A lot of these portable school buildings can be a big problem. Family members, grandma's house. It's not just where you're living, it's where you're spending a lot of time. A lot of these big things, one thing I see here is I'm in the Seattle area, and so Boeing is here, and one of their big plants, there's a lot of chemicals, but there's also really poor circulation of air, and I've seen quite a bit of mycotoxin issues with some of my patients who are working there. So no criticism of Boeing. Some of these buildings can be a problem, and a lot of people will notice headaches when they're at work, or just like they feel a little bitey and their mood isn't so great, and it takes them to decompress. Investigate the home. So we got into this.
Just quickly on that one, police stations in Australia, major problem.
Oh.
Yeah, one guy actually developed cancer and then got a payout of, I think it was like 1.5 million, but ended up passing away. And it was big in the media here. Here's a case of mine. Yeah, he developed neuroendocrine cancer and it was accepted as being mold.
Yeah,
due to
my
exposure to
local
a police
post
station.
office is the worst. Yeah, they've had so many issues. You can barely walk in there. I worry about them. It's horrible. So investigating the home, we have a whole module on this in the course, but ERMI testing can be really good. Some of the mold plates can be good. We talked about this a little bit in our last little pre-launch freebie if you wanted to look at that. And then some easy screening tests, visual contrast sensitivity testing, which is just an eye test, some very simple blood testing that's covered by insurance. I went into that quite a bit in our last little pre-launch, and we'll go into it in a lot of detail in the course. And then the organic acid test is probably one of the most useful, I find, if you're going to pay for a specialty lab. It's actionable steps. I only want information if it's going to change my course of treatment, and that one really will. Okay, next slide. So our little sales pitch, stay with us, our course.
Okay. Yeah. So I guess if you guys are feeling that this line of investigation like mold illness is something you want to know more about and want to develop, I guess, more in-depth knowledge and practice of it, we have developed a practitioner course called Mould Illness Mastery, and it's going to be a live simultaneous course. So here are some of the slides that we present. So this is from our first module on what exactly is mold, and then module 2 is on mold, the history of mold illness research, and we go all the way from the 1930s up till the present, looking at the history of what sort of research has been done. And I think it's going to save people a lot of time, because if you go and troll through all that research on your own, it is so many papers, like it's crazy, it's hundreds and hundreds. But I think getting us to summarize it and give it to you, give the key take-home points for you is going to be very useful. And then we go into the major protocols that are out there, including the SIRS treatment protocol from the Shoemaker team, and then the Dr. Nathan and Dr. Krista protocols, and then the newer protocols from Dr. Campbell, just so you have a good understanding of those, because sometimes people will present to you asking specifically for the Shoemaker treatment or the Nathan, and you want to have a good background knowledge of that. But just so you guys know, our particular course is not specifically grounded in any of those protocols. It's based on Amy and my particular protocols, which are specific and are distinct from all of those. So we will teach you how to understand them and how you can request the Shoemaker tests if you want to, or basically some of the key tests and protocols that are used by Dr. Nathan, etc. But that's not the core of our course. The core of our course is based on our own unique insights. So just to mention that.
Yeah,
anything
and
on
one
that,
comment I would say there is the core of our course is presenting all of these different schools of thought that are out there that have helped to shape everything that we know and what's in our toolbox right now. And so what we're hoping to present to you is, let's give you a really big toolbox and teach you a frame of thinking so that you can make a decision that works in your practice for the person that's sitting in front of you, because the protocol is going to look different for each person and what they respond to. And it's going to give you that way of how can I create my own protocol that works for me and the people I work with.
Yeah, that's great. And then, you can see here that we talk about metabolic effects of mycotoxins. And this is Amy's work here on all the different organs that mycotoxins can affect. It's just crazy how widespread the effects are of mold and mycotoxin. And being able to just get a thorough review of that and understand all those different effects quickly so you can explain it to clients, patients, I think would be very valuable. So basically it's 16 modules, including video lectures and resource materials. So it's basically going to be run live over 8 weeks, and therefore it's 2 modules per week. So you guys are going to keep up if you decide to join. There's also a private online group, so that'll be on the course site where you can actually comment and chat, and basically the comments will be basically restricted to the week that we are currently on, or the modules that we're covering in the current week. So if we're covering mycotoxins and remediation, then all the discussion is about that until you move to the next module and we start talking about treatment or whatever it might be, then all the discussion will be on that. So we do ask people not to go out of time and just stay, because then everyone's going through the same learning journey together, and we can keep our discussion relevant to what everyone's learning at that time. And so there's also community support. You can reach out to others who are also part of the course and basically learn together. Okay, do you want to go through some of the modules here, Amy?
Sure. Yeah, so here's the 16 modules. So we'll break it down into 8 weeks. So module 1 is what is mold? What are the ways that it can cause illness? So really getting into depth with that. And module 2 is really going into the history of mold illness. So that slide that he showed on the last one, sort of a really in-depth dive into some of the research there. What have we learned already? What have we still yet to learn? How is this formed where we're at now? And really looking at some of the big influencers in that research that's happened so far. Module 3 gets into the mechanism of mold-related illness. So going in depth of how it can activate histamine, what types of inflammatory responses can happen, all of the different pathways that can get activated and what is happening there. Because I think it's really important that you understand the framework of what could be going on in the background. And it doesn't mean each one of those things is happening with that patient, but if you can understand what might be happening, it can help direct you to how to treat them. Because if you find, okay, this treatment's not working, but this one is, then it's a clue of that's the pathway for them that's not working. What else can I do to support that pathway? So it's really important that you get that foundation there. Module 4 is what are the main protocols for diagnosing and treating mold-related illness? So we're going to try and present a survey of all the schools of thought that are out there, some of the big names, how do their protocols differ from each other? How are they similar? What have we learned with putting this all into play? Just so you can make an educated decision for yourself of what's the right route for you. We're not saying that one person's school of thought is better than another. It's just, it depends who you're attracting and that particular protocol is working for them. And I think it's important that you understand all of the different types of treatment that are working, how they're assessing, because sometimes people are going to ask specifically. They're like, hey, I did all the shoemaker stuff and you need to know who's shoemaker and what's he doing and what would that look like and how come maybe that didn't work for you and you've ended up on my doorstep. Module 5 is building inspection for mold and water damage. So I don't think enough of this is talked about in a lot of these medical classes, but it's important for you to understand what's a good inspector. How do you direct your patients? Because they trust you. So one of the biggest questions is what to avoid. You have to be careful of some of these people who are coming out calling themselves a mold inspector, but they're also the ones doing all the remediation. Yet, of course, they're going to give you this estimate that it's a few $100,000 worth of work versus if it's someone private or someone who's in it because they've lived it, right? Maybe they had mold illness or their partner had mold illness. How do you know what a good inspector looks like? How do you know how to do this? Because your patients are going to lean on you quite a bit to help guide them. And it's tough. It's a tough one. Having just gone through it myself, you know all the things, but man, when it happens to you and you're like, oh, where do I start? Okay, air filters, containment, what do I do? And so we're going to give you a lot of...
It's so stressful. It's so stressful.
It's so stressful and expensive.
Yeah.
Module 6 will be really getting into remediation and what that looks like. So how and when can you remediate a space versus when do you make the decision to just get the heck out of there?
Yeah,
and
exactly.
finances a lot of times are part of that, or how sensitive you are. Once you're sensitized to a particular mycotoxin or mold or bacteria that might be in the building, even little bits of that might trigger you. And maybe the furnishings still trigger you, any of those soft items. So
100%.
Really getting into remediation of like how strict you need to be, and that's different case by case. Module 7 will be history taking with mold-related illness with your patients. I think this is an important one. What are the right questions to ask? How do you dig into it? And how do you really go into it with an open mind? We're not always trying to project that it's mold, but I'm trying to be open that it could be mold. And how do you look at that or go, it's not that, but it could be something else. Module 8 is examination, bedside tests, the basic pathology testing for mold illness patients. So what are some of the things you can do there in the office before you're doing a lot of these blood tests? And what are some of the basic tests and what can it tell you? Do you want to talk about the last 8 modules?
Yeah, sure. So then, okay, we're up to 9. Okay, so investigating the mold illness patient. So we are going to talk a lot about mycotoxin testing, but also various other types of testing, including mold antibody testing, the utility of some of the shoemaker tests such as NeuroQuant and Genie, and so on. We won't spend a huge amount of time on those, but we'll cover all of those. DNA adduct testing and some of the newer approaches as well. And then nervous system and limbic dysregulation in mold-related illness. Now, we're really excited about this, and I've found this to be huge. Now, we are going to have a cameo from Dr. Kathleen King, and we're very excited about that. She's the founder of Primal Trust and the Primal Trust Academy, and she's agreed to come on and present the majority of Module 10 for us. So who better than the inventor of Primal Trust? So she's going to come in and discuss what some of the key things are and some of the practice points, like when do you draw the line with your patients who just refuse to do nervous system retraining? We were talking about that the other day. And people who seem to react to nervous system retraining, how do you work with them? So this is a really big area. And another really, I think, powerful thing that Kathleen has brought to the table here is just the importance of the language that you use when you're talking with your clients and your patients, that you don't induce more nervous system dysregulation in your messaging. So she'll also be talking a little bit about that the phrasing that you use as you go along the journey with your patients and how that can help them, and also how you as a practitioner need to be taking care of your own nervous system as you don't play off each other, you and your patients, because that can be a thing as well. So there's some really great pieces there that she'll be bringing to the table. And we're talking about polyvagal theory, which is very important to understand here. Now, then we'll jump into mast cell activation syndrome. Now, Module 10 and 11 are very linked. So as many nervous system dysregulation and mast cell dysregulation are like a bit of a vicious cycle. So they're interrelated, and it's very rare to experience one without the other. And so we'll talk about mast cell activation and some of the different compounds, how it's not just about histamine, although histamine is a big part of it, but there are many other compounds such as tryptase and serotonin and prostaglandins that also are part of mast cell activation syndrome. And, how you can use various supplements and or compounded medications to assist people with their mast cells, and how it links in with nervous system dysregulation. And that also links in. So really 10, 11, and 12 are all very linked, because then when we talk about super sensitive patients and hyperreactors, we're generally talking about people who have the mast cell activation and nervous system dysregulation all co-occurring, and how you can address these kind of things. And sometimes you have to address these things before you give any supplements at all. And Dr. Nathan's put out a book about the sensitive patient, which has got some really helpful tips in there. And what we'll talk about is how you can work with them, and how, if they all of a sudden start reacting to something, how you can work your way through that and problem solve so you can get them to get back to a place of not reacting again. So then, in general, we just start talking about, in Module 13, just general work with patients with mold-related illness, and just general concepts here, putting theory into practice. What does it mean that we are addressing mycotoxins as well as colonization, as well as GI dysbiosis, as well as mast cell activation? How do we address all these little pieces? And I think Amy demonstrated this really well with her case today, how you can address so many components when you're dealing with mold-related illness. And then we're just going to jump into creating an effective protocol, and we're going to present quite a lot of cases in Module 14 and 15, but it won't just be presenting the cases. We'll go and break them down for you. Like, why did we do this? Why did Amy decide to use glycine here? Why did Sandeep decide to use itraconazole in this case? And just talk you through some of those decision points, because you could say that working with these cases there's a whole heap of little decision points along the way. How do you know what step to take at each point? So we hope that those couple of modules will really help you to feel confident with all those different decision points. And then finally, working with people who have recovered and who might relapse or who want to go further. let's say they want to start working on longevity once they've recovered from mold illness, or they want to know, how do I get back to a normal life now that I've recovered from mold illness? We'll talk about a heap of different topics around this. Of course, that's very important. If you're dealing with this, you need to know how to help people down the track once they've physically recovered. So I think that's a very in-depth kind of syllabus here. If you have a look at the chat, guys, the wonderful Faye has uploaded the PDF files with the outline and the timing, so feel free to download those so you have them in PDF format. So this is the first cohort. We will be running a number of cohorts each year. And so this is starting on the 12th of February, USA and Canada time. And so it's going to be generally run 1 hour earlier to today's time slot. So that's 5 p.m. Pacific, 7 p.m. Central, and 8 p.m. Eastern. And then for Australia and New Zealand, it's going to be 11 a.m. Queensland time and 12 noon New South Wales and Victoria time. If you're in New Zealand, it'll be around 2 p.m. And just to be aware, as we go halfway through the course, the timings in Australia and New Zealand will change, but not in Australia. And that's just because of daylight saving time in the United States. Now, if you're in the UK or Europe, sincere apologies, but it's going to be around midnight or 1 a.m. for you guys. Yeah. If there ends up being a heap of people in Europe and UK, let's see what we can do later on. But at this point, it's very hard to make a time that's perfect for all three time zones.
And you will have access to the recordings. So if those times don't work for you, you will be able to see the videos and the Q&A. And because we will have that group chat available, you'll be able to ask questions during that same week as you're working through it.
Yeah, that's right. So yeah, we want to point out the caveat that this course is not for everyone. Really want you to only join if you're really committed to growing your knowledge and practice of dealing with mold illness. If you're just curious, but you don't feel like you're really ready to grow in this way, then you're probably not ready for this. You need to be able to spare a couple of hours a week for 8 weeks and make that time free. Thirdly, you want to be able to get better results with mystery clients. So that's really important. And actually, that's a really exciting part of it, is that people that you didn't think were actually possible to make progress with, you may find all of a sudden understanding mold illness opens up new horizons for clients you weren't able to make progress with. And then lastly, if you want to get a new stream of clients who are dealing with mold-related problems. And yeah, in my case, it was actually when I learned about this, I actually got hundreds, not just a few. I actually got several hundreds of people turned up on my doorstep inquiring. But I guess that the reason was there was no other mold specialists in Australia or in this part of the world. And so it may not be that dramatic, but I do believe there are mold patients everywhere in the world seeking help. And if you can basically put your foot forward and become one of the experts in your area, you will be able to attract more and more clients who are dealing with this. Anything else to add to all that, Amy?
Yeah, I would just say, even if you don't think you're specializing in mold illness, being aware that mold can be a factor with whatever type practice you have. So if you're new to functional medicine or you're working with chronic illness, just being aware that this can be a component that's contributing to it. And a lot of the treatment modalities that we'll get into, and even some of the diagnostic tools, can help you exclude, okay, it's not mold, but maybe I have some other information from these other tests that we're going to teach you about, or these other treatments that could help. Like maybe it's Lyme, but it's going to help you learn how to deal with your biotoxins a little bit better and some of these other things. So you can apply it beyond mold, even if you're not going to be a mold specialist. But I think it's really good that it's going to teach you just how to have it on your radar and know where to start.
Yeah, 100%. So even if you decide that you're not going to be the person who leads these patients all the way to recovery, if you can be the person who identifies that mold as a major driver and give them good, clear information and then guide them to someone who you consider to be a mold specialist or expert in your area, you've still done that client a huge service. and you've still led them towards recovery. So there's nothing wrong with that at all. That's still very helpful. And that includes health coaches. I just wanted to put in a quick shout out to FDNs, which is functional diagnostic nutrition. Some of the health coaches who are in the FDN college have been able to identify that patients have mold illness and then send them over to me. And that's even been when there's been 5 or 6 or more physicians who have not been able to recognize it. You don't have to be like a high level MD or anything like that to be able to recognize that someone has mold illness. So even if you're a health coach, acupuncturist, any type of practitioner like that, you're just as capable as anyone else at recognizing this. Just want to throw that thought in there. So guys, this is our discount for this launch. For the next 72 hours, if you use the coupon MIM launch, you'll get $100 off the course. So rather than $5.99, it's going to be $4.99. If you have a look in the chat box, let me just confirm that's the case. Yes. If you go into there, you'll see the link lotusinstitutehh.com, Mould Illness Mastery. And just so you guys are aware, to start off with, you're just going to get access to a welcome page. And then the week we start, the week leading up to the 12th of February, you'll then get opened up to module 1. And each week will just get opened up when we get to that week. Maybe a tiny bit of patience involved here. Sometimes people want to just tear through the material, but this is going to be a paced course where you go through it week by week. All right, guys, so that leads us to the questions and answers. And so please go ahead and type in any questions you have in the question and answer pane in the Zoom control panel, and we'll do our best to answer them. We do have a couple already, which I'm happy to fire at you, Amy. Number one is from... So number one is, can mold also affect iron levels and cause hormone disruption?
Oh, absolutely. So I definitely see the hormone disruption very commonly. I see it really impacting adrenal function. So we'll see high cortisol. We'll see this very agitated. It starts with anxiety, and then over time, they're just completely tanked. So I see that. And I also see quite a bit of suppression of progesterone. And I am seeing in my young men a suppression of testosterone. It hasn't been uncommon in some of my men in their early 20s when I'm checking testosterone levels that they're around 200, which is pretty absurd. So just exhausted, it can throw that off, and it can also raise sex hormone binding globulin. So it can definitely disrupt that. I have seen some abnormalities with iron. I see that more with babesia. I do see the iron disruption quite a bit. I'm just trying to think through. Sandeep, I don't know if you have a specific comment.
Well, so one thing is the oxalates. I think oxalates tend to lower iron. That's one piece. And then mast cell activation seems to lower iron levels in many cases. But it's also, if you've got severe dysbiosis and pancreatic insufficiency, your general absorption is going to be down. So I wouldn't necessarily pick out iron that specifically, but I think your absorption of a range of different nutrients is going to be impaired. So it'll be common to have a number of different mineral deficiencies. I'd probably point my finger at zinc even before iron, and B12 and vitamin B12 and things like that. But iron can definitely be amongst it for sure. And especially with parasites is the other thing I find, like blastocystis and so on, you'll tend to get iron deficiency. And, that's often part of the whole picture because you're getting intestinal permeability and reduced gastrointestinal immunity. And therefore, you'll often find in these cases there will often be parasites as well. And that will also then lead to an iron deficiency in some cases.
The other thing I would say is I also see iron overload being an issue. So someone who has an underlying tendency towards iron overload may be more sensitive to mold because they are already quite toxic from the iron. And so I always do, as part of my screening, I always do an iron, a TIBC, and a ferritin. Our ferritin can be falsely elevated in inflammation, and so it doesn't mean a lot if you don't also have the iron study. And so I've seen in some people with hemochromatosis, with that hereditary iron overload. It will creep up over time. And usually when the ferritin levels get close to 100 or start to get a little bit higher, they will be much more sensitive with mast cells and mold illness.
Yeah, that's a great point. Thank you, Amy. So Carmen asks, is the course aimed at naturopaths or GPs?
I think it's aimed at anyone working with patients.
Yeah.
I think having a bit of an understanding in some sort of functional medicine or alternative medicine is helpful, but we're not making that assumption in the course. So part of this also is teaching the framework of how to think about it. So if you're a GP and a lot of this is new to you, this is going to open up your eyes to just even thinking about a bigger way of looking at your patients in general, not just with mold.
Exactly. And we will be talking about prescribing options. And nothing to mention, being a naturopath in the USA is not the same as being a naturopath in the UK or Australia or New Zealand. You've got prescribing rights and so on. And so there's going to be differences there. Amy uses antifungals medications. If you're a naturopath in Australia, you can't prescribe any pharmaceuticals. So everyone's going to have a different situation. And some people, if they can only use supplements, that's totally fine. We'll still be presenting options, and they're definitely not, how should we say, they're not pharmaceutical dependent. However, if you are someone who can prescribe pharmaceuticals, we will guide you on how you can use them and rational use of them. So in which cases it might be useful, in which cases it's not. And again, if you find you have a very severe case and you're not a prescriber, we can also guide you on which cases might be appropriate to guide to a mold literate MD in your area or something like that. So definitely naturopaths would benefit from it a lot as well. Okay. iPhone says, I'm a little concerned. My grandson is about to start a new school, which has water damage, and he has autism. I'm worried.
Yeah.
What can I do? He has been out of school since May last year. So my daughter, keen for Jack to get back to school. Any thoughts on that case? I guess we're not giving specific medical advice, but.
Yeah. So my advice, because this comes up a lot, is check out the classroom. Not every classroom in the building is as toxic as the others. As a parent, go in, check it out, observe behaviors of your child, especially the first couple weeks when they go back to school. Are their eyes looking like kind of puffy? Are their behaviors off? Is there more stimming? Is there sleep disruption? Is there constipation? And it's hard with autism, right? Because symptoms come and go. You can consider, if you don't have other choices with the school, having an air filter, like a good HEPA air filter that has a micro HEPA filter, run in the classroom. A lot of times the teachers really appreciate that. Depends like how sensitive you are to mold. I don't think I've had some kids with known mold illness and we've gone in and fogged the classroom and done some other things. But I think really observing, you can also use, if the child will use a nasal spray, just even a saline nasal spray after school can be really helpful to rinse out those sinuses. Now, that's not always easy in a child, especially a child with sensory issues. But I think just a decent air filter and possibly getting them on some glutathione or some binder could be good. But really just watch and see.
Great. Thank you for those tips. And then Tanya asks, what about low zinc and low copper? Is that a pattern you sometimes see in mold illness patients?
Yeah, I see it in most of my chronic patients. I see low zinc especially. Low copper is a thing. It was interesting just in rounds today. We were talking about the low copper, that sometimes that can set you up for copper issues that can be a big issue with a lot of things. So I typically check a red blood cell zinc level rather than a serum zinc. I find it's much more accurate to look at what's going on intracellularly. A lot of times we're seeing that's low. Are people with low zinc really are poor excretors. They tend towards a cryptopyruria, often are also low in B6 and can excrete those toxins as well. So zinc replenishment is really important. I especially see the low zinc in those that tend to get sick every month. Zinc is often a thing. Sometimes you'll see the little visible veins on the cheeks, like kind of the see-through skin, or you'll see the white lines in the fingernails, or you'll see eating disorders. I tend to see that. And then with the copper deficiency, we're seeing more mitochondrial presentation. So a lot of the fatigue, the lack of stamina, the lack of growth in kids, the poor recovery, exercise tolerance.
Thank you for that. response. And then Kay asks, how long approximately is each module or each two modules each week online? And then there's a separate question. Mold issues must be very prevalent in Queensland. I've lived in a few mouldy homes. Thank you. This has been very informative already. Very grateful.
Good. I think we were aiming at, so is part of this is still being written. A lot of it is there, and we're trying to, as you can tell, we're both big talkers, right? So part of it is how do we limit our talking, but not restrict too much what we're teaching you. So our goal is that each module was about a half hour. And so there'd be about an hour of video presentation every week and then a Q&A to follow. Sandeep, is that what you agree with?
Yeah, that's right. Sometimes it's gonna blow out a little bit, but generally the live component will only be an hour, but there may be some homework we'll need you guys to do, like watching another one or two videos in your own time. But you can expect with those calls every week to be about an hour, and then questions and answers for roughly half an hour like today. Does that sound all right?
And if we really get into it and there's an interesting topic, we can let the Q&A extend so we can really get your questions answered.
Okay. Kay says, I'm happy if it blows out.
You're happy if it what?
If it blows out, meaning goes longer.
Oh, yeah.
So the other bit, the other question she had about Queensland, I can jump in on that one. That's where I live, obviously. So one thing is that humidity can definitely be a factor, but often people think that climate is the main factor in mold, and I would say it is a factor, but it's not the main factor. And the main factor is going to be the building itself. So, for instance, the converse. So yes, it's common to have mold problems in somewhere like Queensland, which is tropical and subtropical climate, and most people will need to use a dehumidifier to prevent it. It's similar to Bali and other places in the world, I guess Florida and San Diego and places like that in the US. The humidity is just going to be higher. And however, generally speaking, for a major mold problem to happen, you generally need some structural problems as well. So for instance, living in I've actually had some patients who said, okay, we're going to go live in Las Vegas or near there in Nevada, in the desert. And that doesn't necessarily guarantee. So climate's one factor, but I would say the slightly bigger factor is the building design. But it doesn't help if you've got a really humid environment. I hope that helps.
If you have a humid environment like I've seen in Florida, because there's hurricanes and there's a lot of water damage, or in New Orleans where they're below sea level and there's a lot of flooding, definitely a bigger issue. But it was interesting. I talked to a building biologist and they actually said some of the worst mold issues that they see in spaces were in Arizona, which is a very dry desert type climate that's very hot. And they said it's because the differential, the AC is on. So it's hot and dry outside, but the air conditioning is on and that forms condensation a lot of times in the spaces that you see. So.
That's right. Yeah. Dr. Ackley, she's in Tucson, and she sees heaps of local cases of mold, so definitely possible. Sharon, who's one of our patients, asked, can I do this course? I'm not a practitioner.
I'm going to say yes.
Yeah, basically, I think today would give you a good guide. If you feel that this level of information is something you can keep up with, because some of it's a little bit more at practitioner level. If you feel it's something you can keep up with and that it's going to be useful for you to help guide yourself and maybe family members, then that's totally fine. But obviously, we're not recommending it as a guide for self-treatment. We still recommend working with a practitioner, and I guess you're working with us anyway, Sharon. I think it'd be lovely if you think if you think that getting deeper into it and understanding some of the intricacies would be useful, you're more than welcome.
And then you can become a health coach and help other people.
Yeah, that's right. Actually, a lot of people do that. A lot of people who go through mold and things like that, their whole life changes because they've had to direct so much time towards their health that their whole way of thinking about life changes. And it's almost natural for them to then look at changing careers towards being something like an FDN practitioner or a health coach, etc., and start helping other people. So it's a huge thing once you've gone through mold and MCAS and so on. Like you're basically, if you address it full on, you're going to be a totally different person at the end. So I do believe it's a very strong a strong kind of tap on the shoulder towards personal growth as well. So that's a really positive thing that can come out of mold and mast cells, and you could guide people through that. So yeah, I think it would be great, Sharon, if you'd like to do it. So thank you so much, everyone, for joining us today, and I hope you've got a lot out of this webinar. And thank you so much, Amy, and also Caleb in the background there, and Faye, who have helped us with the back end of this. Very grateful.